Good evening, everyone. Thank you for joining us tonight. We might just give it a couple of minutes to let some stragglers log in. Thanks, everyone. I might just give it one more minute before we start. All right, perfect. Thank you, everyone. Good evening. Welcome to tonight's exercise, sport and fertility webinar. My name's Lisa and I will be your host this evening. Before we kick things off, I would just like to begin with an acknowledgement of country. In the spirit of reconciliation, Monash IVF acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. So my name is Lisa and I will be your host this evening. I'm the team leader of Monash IVF's nurse inquiry team. I'm incredibly fortunate to work alongside an amazing group of nurses who are essentially here to answer all of your questions. It is a real privilege getting to speak to people every day, hearing their stories and discussing their options so they can make an informed decision about their fertility pathway. I will talk a little bit more about the nurse inquiry team and how you can contact us a little bit later on in the presentation. But first, let me tell you a little bit more about Monash IVF. We are committed to empowering the next generation of parents on their journey to parenthood. We are here for people at all stages of their fertility journey. We're proud to support patients of all genders and sexualities on their pathway to parenthood. The entire Monash IVF team are incredibly passionate about the care and support we provide our patients. In terms of where you can find us, Monash IVF provide world-leading scientific and medical services right across the country. We have clinics located in Victoria, New South Wales, Queensland and Western Australia, and we also have sister clinics in the Northern Territory and South Australia. Here is a list of the services we offer. We provide comprehensive reproductive care. So we offer everything from fertility testing right through to IVF, IUI and ICSI. And of course, we also support a variety of donor treatment options. So here is a quick look for tonight's webinar at the agenda. So we've got Professor Beverly Vollenhoven joining us, and she'll be running through reproductive challenges. Dr. Chris Arthur will be speaking on exercise and fertility, and Kirali Tutt and Dr. Cecilia Kiddick will be running us through their experience on how nutrition and exercise impact fertility and conception. I will be introducing our speakers in just a moment. Before I do, just so that you know, our specialists will be sticking around at the end of the presentations to answer your questions. So if anything does spring to mind throughout the evening, be welcome to submit your questions using the Q&A button at the bottom of your screen. We will do our very best to answer all of your questions, but we may not get to all of them tonight. However, it is really important to us that you get the information you need. So if your question isn't answered, we do offer complimentary phone chats with my team of experienced fertility nurses. So the nurse inquiry team can provide you with advice about what your next steps could be and answer any questions you may have about fertility or fertility treatment. My team can also assist in organising appointments with our specialists if you're at that stage. So there is a QR code up on the screen there that you can scan to book in a complimentary nurse chat, or you can also do so via our website. Before I get into our introductions, I would just like to read a little disclaimer. So whilst we will do our best to be affirming, we just want to mention that this webinar may include gendered language or medical terms. We know that not everyone identifies with these terms and that people may use different terms to describe themselves or their bodies. We're proud to support patients of all genders and sexualities. Everyone is most welcome in our clinics. The information provided in this webinar is general in nature and does not replace personalised advice from medical professionals. So our first presenter this evening will be Professor Beverly Vollenhoven. Beverly is a reproductive endocrinologist and infertility specialist who has been caring for patients at Monash IVF since 1996. Beverly is also a professor at Monash University and head of gynecology at Monash Health, and in her spare time has also published over 170 publications. Being able to bring evidence-based research to patient-facing care makes her a fantastic addition to tonight's webinar and a great resource if you have any questions you'd like answered. Beverly will be speaking about reproductive challenges as our first speaker this evening. Our second presenter will be Dr. Chris Arthur from Queensland. Chris is a fertility specialist, gynecologist and obstetrician with a background in sports medicine and reproductive medicine. He's got a thorough understanding of how movement and exercise can positively impact our health and fertility. And with his background in not only sports medicine, but also playing and coaching, he's a great addition to the webinar and a fantastic resource to ask your sport and exercise related questions. In our second session, Chris will be speaking on exercise and fertility. Our final presenters will be Kiralee Tutt and Dr. Cecilia Kiddick from the IVF Project. Kiralee is a fertility dietitian and after working as a sports dietitian, developed an interest in how gastrointestinal health and nutrition can impact fertility. It's great to have a nutrition-focused perspective tonight, and Kiralee is a great person to ask for questions concerning nutrition and its impacts on fertility. Dr. Cecilia Kiddick is an exercise physiologist and director of the IVF Project, specialising in immunology, gut microbiome, and preconception health. With a background in supporting conception for female athletes, she combines academic expertise with clinical practice. In our last session, Kiralee and Cecilia will be providing advice to ensure that your exercise habits and nutrition support your reproductive health. So without further ado, I would like to now hand over to Beverly for our first presentation. Thanks, Beverly.
Thank you so much, Lisa. Really appreciate the opportunity to talk to everyone today about this important topic and a question that I'm often asked about by my patients. So just to give some sort of statistics, 1 in 6 Australian couples will experience difficulties getting pregnant. And the older one is, the more likely they are to experience difficulties. Can I have the next slide? So there should be no blame on either party when infertility is experienced, because 1/3 of infertility is female, about 1/3 is male, and about 1/3 is either unknown or a combination of factors. And when we say unknown, we mean that we've done all of the tests to see if the female is producing and ovulating eggs, the male's producing sperm, the woman's tubes are open, but for some reason they do not become pregnant. So this is called unexplained infertility, and as I said, probably affects about 20%, and the combination is probably about 30%. Next slide. So you might have read in the paper recently, I think it was this weekend or this last weekend, our fertility rate is going down quite dramatically. And as you can see, it continues to go down. In South Korea, for example, their fertility rate is so low now that they actually will not sustain their population. So this is actually quite an important issue for the future. The next slide. So the other interesting thing that is occurring, and this may also be why our fertility rate is decreasing, is that you can see from 1961 up to 2020 that the number of people, or the number of women, because it's predominantly women's age that is affecting their chances of pregnancy. Women are older when they give birth. So, for example, in 1961, about 3.4% of women were older. Now in 2020, 14.2% of women are 35 to 39, and 3% are 40 years or older. So this may also be one of the reasons why our fertility rate is decreasing, because women are waiting longer to become pregnant for all sorts of circumstances, and then have difficulty getting pregnant, and may in fact never get pregnant. The next slide. So as I said before, age is really important because it affects eggs. Now, women are born with the greatest number of eggs they're ever going to have, and then after that, it's really downhill. So women go through menopause around between the ages of 50 and 52, and this is usually because they run out of eggs. So from birth, the numbers of eggs that are present are decreasing constantly, and then there is a decrease in the 30s, and then a steeper decline in the 40s. So really, optimal fertility is in women in their 20s. And now a lot of women in their 20s are certainly not ready to become pregnant, but this is certainly when fertility is going to be it's at its highest. The other issue with fertility decreasing or egg reserve decreasing with age is that a woman in her late 30s may become pregnant, but may not ever have another child because the time left for conception is a lot less. So there are going to be more one-child households in the future also. And some of this may not be from choice. So I think we missed a slide. Can we go back? Oh, maybe we didn't. Okay, sorry. So what happens with the male, and how is the male affected in reproduction? Well, we used to think overwhelmingly that this reproduction was a female problem in terms of age, but we now know that it also relates to the male, but it's not as significant as with the female. So men's sperm count, which is what we measure when we do a semen analysis, we measure sperm count, movement of sperm, and how the sperm looks, its morphology. There's a slow decline that we know into older age. But we also know that many older men can successfully father a child. But there are increased issues to be reckoned with for infants born to older fathers. So one issue is that autism is much more likely when a male is older. Schizophrenia is more likely, and there are certain genetic disorders that are more likely. One of these genetic disorders is achondroplasia or dwarfism. So we know that sperm quality decreases with age, and also the risk of miscarriage is higher if the sperm provider is over the age of 45. So what we do know for couples is that if you have a couple where a woman is young and a male is over 40, then you have another couple where they are both young, they're both in their 30s, let's say, and you've got a third couple where the woman is older and the male is older, and you've got actually a fourth option where the woman is older and the male is younger. So the couples that are going to do the best are the couples where both partners are younger. The couples who are going to do the worst are the ones where both partners are older. And the couples in between are the ones where the woman is younger and the male is older, because we do know that the woman can sometimes, her eggs can sometimes fix problems that are occurring with the sperm. So that's an interesting, observation that we've had, and that was published by one of my PhD students at Monash University. The next slide, please. So what are menstrual problems that may indicate an underlying fertility issue? So a woman may have painful periods, and these may have become painful as they have gotten older. This can sometimes indicate endometriosis. That she may also have heavy menstrual bleeding. So this can indicate sometimes that she has fibroids, sometimes can indicate that she has adenomyosis, which is really endometriosis in the uterus itself. An absence of periods means that the woman is not ovulating and is therefore sterile, though I don't like that term, but that's the sort of scientific term or the medical term for it. So there are a variety of reasons why women may not have periods. They may not have periods because they've actually gone through menopause early, which is obviously something that can't be rectified, but they may also not have periods because they have an eating disorder or because they are exercising excessively, which is one of the topics that we have today. So clots, large clots, or the passage of clots during a period is also not normal, and this is an indication of heavy bleeding, and as I said, may be due to fibroids or adenomyosis. Long periods also similarly may be related to these two conditions. A woman may be having periods, but they may be irregular. And so irregular periods are periods that occur anywhere from 21 to 42 days. And these irregular periods may indicate a hormonal disorder such as PCOS, which is a very common hormonal disorder. And then bleeding between periods can indicate usually that there is something pathological going on, there's something going on in the uterus, and this may be an endometrial polyp. So any changes in the pattern of periods may not be completely normal, but also it's important to understand that as women get older, the pattern of their periods are going to just naturally change. Next slide. So what are the conditions that impact eggs in the uterus? I've kind of spoken a little bit about this already. So polycystic ovarian syndrome is the commonest hormonal disorder affecting women, and this can affect ovulation, and this can then lead to infertility. Having said that, about 60% of women become pregnant without any issues at all and don't need help at all. Blocked or damaged tubes, fallopian tubes, will prevent fertilization because the eggs and sperm, which normally meet in the tube, cannot meet together. And so the commonest reason for blockage in the tubes is from pelvic inflammatory disease. The most common cause of pelvic inflammatory disease is chlamydia. And then endometriosis can also affect fertility, and it really depends on how severe the endometriosis is as to the potential effects on fertility, and adenomyosis is often present in women with endometriosis. The next slide. So again, so the conditions impacting sperm, low rate of sperm production. So this often means that there is something, there's a hormonal problem within the testicle itself. Absent sperm, so this can again be an issue within the testicle itself, or it can be because there's a blockage, which is one of the next points, in the vas deferens or the epididymis. So the commonest reason for an issue for blocked tubes in a male is also a sexually transmitted infection, such as chlamydia. However, there are some men who are born without a vas deferens, and this is the tube that leads outside through to the urethra. So men who have cystic fibrosis or who are carriers of cystic fibrosis, which is not an uncommon genetic condition, can be born with an absence vas deferens. Now, the most common reason probably that someone has a blocked vas deferens is that they've had a vasectomy. And there are other rarer causes for no sperm to be produced, and these are related to what's going on in the brain, where the messages from the brain to the testicle are just not occurring. This condition can actually be reversed. It does take some time to be reversed, but it can actually be reversed using hormonal medication. My next slide. So thank you, and I'm happy to answer questions. The next speaker is Dr. Chris Arthur. So take it away, Chris.
Thank you very much, Beverly. And I start that, and hopefully there I am, if it's working. Good. Good everyone, I'm Chris. I'm going to be talking on exercise and fertility. And so why are we doing that? Well, it's important to know what a healthy body is and to be informed about the impacts of the exercise, positive and negative, on your reproductive health. And to think about causes of amenorrhea, which is when you're not getting a period or a dysfunctional cycle, because there can be some longer-term health issues associated with those. So what's normal? What are we supposed to be doing, actually? Is probably a better way of phrasing it, rather than normal. So we suggest that we should be active most days, preferably every single day of the week, for 2.5 to 5 hours of moderate intensity in total across the week, of moderate intensity, which includes things like brisk walking, swimming, bicycling, or up to about 2.5 hours of vigorous physical activity with games and sports such as netball or soccer or jogging, or a combination of those two. And it's preferable that muscle strengthening activities comprise the exercise and activity on 2 days per week, and that's things like pull-ups, push-ups, and weightlifting. The general benefits of this sort of activity and exercise, it's considered that it possibly increases or at least maintains the lifespan by about 6 to 7 years if you adhere to that moderate exercise program. There are benefits in lowering blood pressure. It can improve cortisol, which is a really sexy hormone at the moment. Every time I open Instagram, it seems to be somebody talking about how to change cortisol. It's a stress hormone, and particularly the exercise moderates your ability to cope with stress, and stress-induced cortisol rises. It can decrease the incidence and the prevalence of anxiety and depression, helps maintain and develop bone density, moderates blood sugar levels, and also importantly aids with weight loss and weight gain prevention. So apologies to Prof. Vollenhoven for this picture here. She is probably sitting there with her face in her hands thinking about all the lines that I haven't drawn in there. But I think what's important when we're talking about fertility and the impacts that exercise can have on your ovulation and your chances of falling pregnant, to have a bit of an understanding and appreciation of the background cycle. This thing called the hypothalamic pituitary ovarian axis, which is the cycle that we talk about when we're thinking about ovulation. So at levels that I can understand, we've got the hypothalamus that's a bit inside the brain, produces a hormone called GnRH, or gonadotrophin releasing hormone. Gonads just mean testicles or ovaries. Troph is an ancient Greek wording meaning nourish or feed. So we want to release the hormone that feeds the ovary. The pituitary then releases primarily initially follicle stimulating hormone, and follicle begins with F, and so does feed. So we know that that's the hormone that's going to go off to the ovary and encourage the maturation process for the of the ovaries and the follicles, the eggs, try and encourage some of them to move towards ovulation. As part of that process, they produce estrogen, and it feeds back in a negative fashion to the start to dampen that process down so that you're not constantly producing eggs and constantly fertile. There's a bit more complex interplay. Ultimately, in the middle of the cycle, you end up with luteinizing hormone being released, and that induces ovulation. Luteinizing just means turning yellow, and the tissue that's left behind after ovulation is yellow, and it produces progesterone. So the first half of the cycle, we're estrogen dominant. The second half of the cycle, we're progesterone dominant. And if you look back at some of these pluses and minuses and go and stop points, the hypothalamus is kind of the center of all this. And we can start to think about different things that might be happening in the bodies or with our activity or our lives that could be having an impact on how well this cycle is working and how functional it is. Next slide, please. And so with that, here's some of the things that can disrupt the cycle. So increased adipose tissue, or we've got carrying a little bit of extra weight, converts that fatty tissue, converts other hormones that are usually produced in the adrenal glands into estrogen. And so we've got then a negative suppression. So we've got the estrogen slowing down that hypothalamus there. And so we're less likely to have a smooth and functioning cycle. Conversely, if we've got decreased adipose tissue, so if we're in a state of where our body is concerned that we're starving and we're struggling to keep ourselves going, potentially we've been exercising a lot and in a calorie deficit situation, we've got low leptin, which is a hormone kind of letting the body know, or the brain know, whether we've got enough fatty stores to look after ourselves. And so again, if the body is going to suggest that you're in danger of not being able to look after yourself, it's not going to want you to be pregnant and be needing to look after someone else. And so the low leptin and the high cortisol that goes along with that will again suppress the hypothalamus, and so the cycle is not going to be able to progress. In times of increased stress, then we get increased cortisol, and cortisol again is going to cause hypothalamic suppression. And so we end up in a situation where we're not producing our GnRH, we're not producing our FSH, and so we're not ovulating. Next slide. So what are some of the impacts of sport and exercise on female health? If you have an elevated BMI, then weight loss, and even just as little relatively as 10%, can help restore a lost cycle in many women. So if you have been in a situation where that increased estrogen is being produced or being converted into in the peripheral tissues is dampening down your cycle, if we decrease that negative impact, then everything will start to turn on and start working again. Really quite cool in many respects. There's something for PCOS, there's a bit of a dose response. So one of the things we like in medicine and in subsets such as pharmacology, when we're talking about medications and things, is if you give a little bit and there's a bit of a response, and you give more, then there's a greater response, and there's a stronger, potentially at least a stronger association between your intervention and your outcome. And certainly in PCOS, it appears that the higher intensity exercise leads to a better result, even if there's no weight loss. So demonstrating this dose response. And importantly, it improves the pregnancy risk profile. So an increased BMI is associated with increased risk of hypertensive, so blood pressure problems during pregnancy, and gestational diabetes, and trends towards cesarean sections and problems in labour, and all sorts of things like that. And there's also often weight gain associated with a pregnancy, which can put you at a higher risk for subsequent pregnancies down the track. If you're currently sedentary, have lesser activity levels, and potentially have a normal BMI, but engaging in moderate activity anyway, increasing that is rather associated with improved pregnancy rates spontaneously, so being able to fall pregnant without the aid of any medical staff. And importantly, there's also no negative effect on assisted reproductive technology outcomes. So if you do need to go down the IVF pathway, then you're not going to be working against yourself. Something that's really important, and I think it's fantastic that we've got dietitian and exercise physiologists talking after me, is that the best results are achieved not with exercise in isolation, but alongside dietary interventions and with a supportive team around you to help from the supportive team perspective, we really want to try and make this as smooth an event as possible and decrease the stress that can be associated with the whole trying to fall pregnant journey. Next slide, please. Now, the last slide really dealt with most of us, people who do a little bit or aren't doing heaps at the moment, and looking after ourselves from a general health perspective day to day. For the really high intensity athletes, however, they can end up with this functional hypothalamic amenorrhea or dysfunctional cycle. So just a couple of really long fancy words that are meaning that first step, the hypothalamus, is being completely suppressed because of low leptin or high cortisol or a combination thereof. And it's shutting it down completely. So the ovaries really aren't being stimulated, not enough, potentially not really at all. And we're in a menopausal state, but in a much younger age group. It's especially prevalent in weight-dependent sports such as diving and gymnastics, and also in endurance sports where we're using a lot of energy over a long period of time, such as marathon or triathlon. It's a situation where the energy expenditure is greater than the intake. And as we're talking about, the cortisol levels and leptin mediate the suppression. If you are, well, actually, I mean, you don't have to be a high level athlete. Anybody who's not got a regular cycle should be evaluated, because as much as it could be related to the dietary deficit or in the exercise excess, it could also be things like PCOS or structural anomalies, which are going to also have an impact on the ability to fall pregnant. And the one that we really don't want to miss is something like ovarian insufficiency, premature ovarian insufficiency, which is what we now would describe as, or had previously described as early menopause. In those states, or even with the FHA by itself, more importantly, with this low estrogen, there's an impact for the rest of the life. The estrogen is very important for things like bone density, as well as for cardiovascular health. And there's this thing, the female athlete triad, where you've got the energy deficit, no or a very severely disrupted menstrual cycle and low bone density. And it's something that you, regardless of fertility desires, we're wanting to replace the estrogen in order to try and decrease the longer term risks to that individual. To kind of really hammer home the point, over-exercising is stress on the body. Athletes and individuals who over-exercise can have difficulties with conceiving. The stress suppresses the brain hormones of the GnRH, and so moderation is the key. If you're worried that you're over-exercising, or if you're concerned about dietary intake or wanting to start an exercise program, I think it's certainly worth talking to your GP or a fertility doctor, as well as exercise physiologist, dietitian, to try and help you achieve your goals and make sure that we're working as a team, as I was talking about before, to make it as smooth and as simple a process as possible. Now, it's not all about the eggs. We also do have to think about the sperm. And with the first line here, many of the studies that look into sperm health have actually just spent time, not quite with stopwatches, but recording activity, but also specifically time watching TV. And the more time is spent exercising, the less time spent watching TV, the better the sperm concentration and count. There is a bit of a question mark over cycling as an exercise for men because of testicular pressure, pressure on the nerves and the blood vessels supplying the testicles, as well as the temperature surrounding them, as sperm really like a pretty narrow temperature range. Certainly a lot of cycling is potentially deleterious to the counts, but doesn't seem to make too much of a difference in terms of ability to produce a pregnancy. Lots of distance running, which is another one that the people have been more worried about from an energy deficit, but also a heat perspective, doesn't seem to be as much of a concern. Something that's pretty popular around where I live here on the Gold Coast are steroids for appearance, more so than athletic performance. And we've talked about the HPO axis, so the hypothalamus pituitary ovary. We've got the HPT in guys, and it's essentially exactly the same thing. Only we substitute the testicle for the ovary, and instead of estrogen, we're talking about testosterone. And if you've got testosterone being supplied, then we're going to downregulate the ability of that guy to produce sperm. So if you're wanting to fall pregnant, or if you're wanting to fall pregnant, you want your male partner to stop any of the steroids. And if you're a guy who's watching and you're wanting to try and assist your partner fall pregnant, then you should also be stopping those things too. Any guy who's been previously sedentary and then starts a regular physical activity, that improves their fertility, the same as with a woman. Moderate is best. Elite training can affect quality, but it appears that certainly with donor specimens, very high physical activity rates, although the counts might not look quite as good as they otherwise could, the practical outcomes in terms of pregnancies and live births don't seem to be affected. Next slide, please. When it comes to actually being able to do exercise, it's important to think about any barriers. And from a gynecological perspective, some of those can be things like heavy bleeding, where you could be anemic and struggling and physically to be able to get up and do some of the activity that's required, as well as the concerns about embarrassment, or the physical interruption with needing to change pads regularly. PMDD, so just not being able to, from a psychological perspective, go outside and do active sports. And then pain from endometriosis. If you're in pain, you're also similarly less likely to be able to get up and go and do things. Now, whilst I would tell you from an academic perspective that exercise has been demonstrated to improve outcomes with things like PMDD and endometriosis, it's also pretty hard to get started in the first place if you're just curled up in a ball crying. So those concerns need addressing before, really, but definitely alongside, depending where you are in your journey, fertility concerns, because we would like to, they will all have an impact upon your ability to fall pregnant in the first place anyway. Next slide, please. So what sort of exercise should we be trying to do or trying to avoid? There's not too many to try and avoid, really. Any exercise is beneficial when you're trying to conceive, preferably done in moderation with proper precautions, such as stretching, warming up and cooling down. It's really important to choose exercises you like to increase the chance that you're going to continue to do it and to decrease stress. Interestingly, well, I think, at least anyway, there is fortunately quite a small subset of people who, and it's typically in the elevated BMI PCOS population, who exercise hasn't been shown to always improve things. And it seems to be that it's in somebody who's doing it because they've been told they have to, and they don't like doing the thing that they're having to do. And so there's an increase in stress. They're stressed that they're not falling pregnant. They're stressed that they have to go and do the running's not fun for everybody. They're stressed about going to do running. They hate doing the running, and they're stressed whilst they're doing it, and they're stressed that it doesn't seem to be making a difference. And so they're getting that marked increase in cortisol and other mediators, and that ongoing suppression despite doing the right thing. So if you can find something that you enjoy, if you can talk to your exercise physiologist and try to work out a program that's going to work for you, you're more likely to stick with it, more likely to do it, and you're also less likely to be stressed by it and to actually get that positive benefit with a decrease in your cortisol levels. Low impact exercises like swimming and brisk walking and yoga and Pilates and cycling, particularly on stationary bikes, it's very hard to get very hurt doing them. That's one of the downsides. I haven't talked too much about the risks of exercise other than in cases of excess when you're able to suppress your HPO. But you can do injuries in particular, which can make it harder for you to continue with exercising and can make even work difficult depending on what you manage to injure. So these sort of lower impact exercises are less likely to end up with clinically significant, socially significant injuries. Next one, please. Thinking about the far end, so we've been through the pregnancy, we've got through the pregnancy, or whilst being pregnant even. It's important to have a strong pelvic floor and core muscles. Weakness can lead to back and pelvic pain during the pregnancy and more troubles afterwards. Some people have some difficulty identifying and activating those muscles, and it can be quite a difficult thing to do. And I think it's really useful to talk to a pelvic floor physiotherapist before trying to fall pregnant to try and get everything optimized so that when it happens, you're ready to go and in the best position, and you know how to deal with any challenges that are potentially going to present during the pregnancy. So the overall takeaways: exercise, even in the absence of weight loss, has been shown to, for the vast majority of people, increase the chances of conception. If you're not doing it at the moment, now's a good time to get started and get into it and to try to create preferably some good lifelong habits, and establishing a good exercise routine will help ensure a healthy pregnancy. But as with most the fun things in life and good things in life, you just got to remember to not overdo it. And so that's the end of my bit, and I'll look forward to any questions later on if you've got them, and I'll hand over to Kiralee and Cecilia with fertility, fuel and movement.
Thank you, Dr. Chris. My name's Kiralee. I am a sports dietitian working at Apple to Zucchini Performance Nutrition, and also a fertility dietitian working at the IVF project with Dr. Cecilia Kiddick. And together we're going to cover some insights on fertility, fuel and movement and how that can support conception. So we're going to dive straight into the sports nutrition for fertility. So I guess working across both of those clinics, in both the sports and fertility clinic, one of the things, most common themes that I see is that people are not supporting their training sessions effectively. And an example of that would be that people may not be changing their nutrition at all on the days that they're training versus the training that the days that they aren't. And so importantly, we actually need to make sure that we're at least increasing our nutrition, at least in that sort of before training time, on top of your regular meals. So what do we look for before training? We need to focus on having some carbohydrate foods. So what carbohydrates are doing there is they're providing energy for the session. They are the muscles' fuel. Carbohydrates are the muscle fuel. And so that energy is going to be there and available and ready while we're doing the session. And it's also going to help with optimizing our energy levels as well, making sure you're not having low energy spells across the day. So if you're training, say, for example, before breakfast, you would need to have a pre-training snack containing carbohydrates. So it could be some toast, it could be some fruit, it could be some cereal. If you're training in the afternoons, say after work, you would just have your usual afternoon tea. And then in addition to that, just before you start training, so in that sort of 30 to 60 minutes before, have one of those pre-training carb-based snacks to support that training session. So after training, what we are trying to focus on here to kick off recovery is both protein and carbohydrates. So if we're looking in that breakfast meal, if you've trained before breakfast, then that's going to be your recovery meal. If you're a cereal person, then the protein in the milk and say a high protein yogurt would cover off that protein component, and a nice whole grain muesli or something like that would be the carb-based component. Or if you like eggs, then your eggs would be the protein component, and potentially some whole grain toast and maybe some avocado to help kick off that recovery and making sure that your body is really feeling well supported for those training sessions. The types of training that we're looking to support here are going to be predominantly strength-based training sessions, and in any of those kind of high intensity or interval-based training sessions, we may not necessarily need to provide that extra support or the additional pre-training carbs on those lower intensity or more gentle sessions. Sorry, can I just go back to that slide? I forgot to say one thing. Thank you. If you're training after work in the afternoon, we're hoping that you would have some protein and some carbohydrates, maybe some whole grains on your plate, and then also that color component, and that would cover off that sort of recovery meal in the evening. Thank you. Okay, so working as a sports dietitian, we do get a lot of referrals with clients experiencing relative energy deficiency in sport, which Dr. Chris was mentioning there before. And the nutrition component of that is what we call problematic low energy availability, and can result in the loss of a menstrual cycle, And of course, as a fertility dietitian, some of the work that we are doing is supporting people trying to conceive, and they may have those disrupted menstrual cycles as well, whether they're not there at all or they're a bit irregular. So some of the indicators that we are doing in our looking for in our nutrition assessment, where there might be inadequate fueling, is going to be those low energy levels. So it doesn't matter what you do, you just can't get on top of the energy levels. So that is an indicator for me that you're just not supporting those training sessions very well. Potentially a low appetite. You might think that if you're not fueling enough that your body would, make you more hungry, but sometimes that can actually play tricks on us and it can suppress your appetite. So that's something that we do look for as well. So in the absence of things like PCOS and your menstrual cycles gone missing, the low or problematic low energy availability or inadequate fueling can cause that absence of your menstrual cycle or irregular cycles, or if you do have a menstrual cycle and you're trying to track it and you just know that you're not ovulating, there's definitely nutrition components as well as that short luteal phase. And so what we would be looking for and trying to focus on there is the adequacy of your entire diet and also the distribution of that energy intake across the day, as well as your total carbohydrate intake. So we don't want to be seeing any really long periods without eating, as that can really disrupt our hormones. You may be feeling like you're recovering very poorly from your training sessions, the bone health concerns that Dr. Chris also talked about. And we know with that relative energy deficiency in sport, especially, that there's gastrointestinal symptoms that can go alongside with that problematic low energy availability. And we also know that there's gut microbiome disturbances in females with hypothalamic amenorrhea. Next slide, thank you. Okay, so this is a very short snapshot of some nutrition tips for fertility. So it really easy one to kind of start off with is making sure that you're regularly eating across the day and that you're eating adequately. So we definitely don't really want to be recommending or seeing any types of fasting, because that will really put a dampener on that nutritional adequacy. As a kind of bang for buck tip here, making sure that we're focusing on those really nutritious foods that are high in antioxidants and fibre. So it might be your berries, it could be dark green leafy vegetables, whole grains, and oily fish such as salmon. We do know that antioxidants play a really big role in fertility. And there was a 2024 paper that looked at the association with infertility risk, and the people that had the lowest risk of infertility had the highest antioxidant intake, and that was actually irrespective of BMI as well. We'd encourage people to explore gut health issues. I see a lot of people with gut health concerns in that fertility clinic. And we also know that there are disruptions in the gut microbiome in patients with PCOS, endometriosis, and even unexplained infertility. Making sure that if any of those indicators of inadequate fueling struck a chord with you, just checking in on any of those red flags and getting a referral to a sports dietitian or a fertility dietitian to help with supporting both your exercise and your fertility goals. I'm going to hand over to Cecilia now. Thanks.
Hello, and thanks for having us here tonight. It's super important information in the context of understanding what factors are actually impacting fertility. And when we're talking about the best opportunity for conception, it's coming to the party with a beautiful, healthy egg, with quality sperm, and also a beautiful, receptive uterine environment. So we're really interested in exploring the evidence-based strategies that we know can actually change those ingredients in the process of getting pregnant. If we go to the next slide, some of the key contributors to impacting the quality of our eggs and sperm and uterine receptivity relate to the processes of inflammation and oxidative stress that can take place in the body, which are usually really well regulated, but sometimes, particularly in different conditions like endometriosis and PCOS and male factor fertility, we can see disruptions in those processes that might lead to a little bit more cellular damage. Now, exercise is one of the most potent non-pharmacological anti-inflammatories out there. And if we could package all the benefits of exercise into a pill, it really would be the most highly prescribed medicine on the planet, because exercise is impacting our mental health, our metabolic health, our immune system function, our liver function, our endothelial health, our vascular health. All of these aspects are impacted with physical activity. And these are all factors that impact our fertility. So we saw before Dr. Chris Arthur was presenting the physical activity guidelines in Australia. These are because exercise is known to impact our health and well-being, but it might not necessarily be a one-size-fits-all in the context of fertility. So we'll break that down a little bit. But with the guidelines, we saw it's roughly getting up to 5 hours of moderate intensity activity a week. And when we say moderate intensity, we're sort of talking about heart rates around about sort of, 50 to 60% of our maximum heart rate. We could also, though, trade off that big volume of 5 hours of moderate activity and do a smaller amount, maybe 2.5 hours of vigorous activity. But that vigorous activity intensity spans quite a range in our maximum heart rate. And we know we get different adaptations across that whole gamut of intensity there in the vigorous. So we can still do a bit of both depending on the circumstances. And of course, strength training is a vital component of that. And importantly, how is that spaced across the week? Because two people can do the same bouts of strength training, the same bouts of aerobic exercise training. But if one structures them where they're all packed up together and all fitted into 2 to 3 days, that's quite different adaptation and load as opposed to someone that's spreading it out across the week. But it's crazy to think that 55% of adults are not even meeting the sort of minimum requirements. So it's important to start with your physical activity as to where you're at that point in time. The next slide. Okay, so just a global sort of summary in terms of some of the benefits of physical activity. You've already heard, but in certain populations, it can mean a 3 times higher chance of pregnancy and live birth. And in males, we know that doing physical activity will change the structure and integrity of their sperm. So it is going to change a lot of the semen parameters that can be measured in a standard laboratory, but it's also going to be changing the DNA integrity of that sperm and supporting that for better health, which means our egg has to do less repair work. So it's very much a team effort. Physical activity will change uterine receptivity. It will change our egg quality. It will change our sperm quality. In males that start to undertake structured resistance training, pregnancy rates can increase by 2 to 15 times. So this is an incredibly important tool to consider putting into your preconception preparation. Oh, just the next slide. So when we always get asked, particularly by exercises, how much is too much? And there's no specific answer. We need to look and consider a few different variables to really understand if someone is doing too much. So if, for example, your current fitness level, you haven't been doing anything structured, then going out and doing 5 hours of physical activity in 1 week might actually be a bit too much. Whereas if someone's training regularly, they're used to high intensity activity, then that's going to be factored into what's suitable for them. We really want to understand the factors that are impacting reproductive health. Are we prescribing an exercise for someone that's dealing with IBS or irritable bowel disease? Are we prescribing exercise for someone with PCOS? Does someone have endometriosis? Are they having like polycystic kidney disease? Are they dealing with unexplained infertility, where we know that about 70% of people will present with higher levels of inflammation and oxidative stress. So if we understand those factors that are playing a role in fertility, we can really understand what type of activity we want to be prescribing for them. It's important to factor in current lifestyle demands as well. If someone is an athlete and they're able to train and not working full time, they've got a very different recovery process to someone that is training the same amount, but then still having to go to work full time. And thinking about what other life demands are happening at that point in time, what other stresses are going on. Even if someone has been on antibiotics, we have shown that that reduces the motivation to exercise, it's changing the gut microbiome, and that can even have flow-on impacts then to the structural aspects within our skeletal muscle. So we sort of need to factor in all of those current lifestyle elements to inform that. When we're talking about females that might be experiencing a irregular ovulation, or that they have lost their menstrual cycle for a period of time, we are going to dive into the underlying cause of that. And of course, then understand and monitor those characteristics of even their luteal phase length, how much progesterone someone might be making after they ovulate, which is a great sign of how well our corpus luteum is working in producing that, looking at any symptoms of PMS. It's possible that you can have a regular menstrual bleed but still not be ovulating. And that happens in about 16 to 37% of menstrual cycles, because there are many things that have to be fine-tuned for us to ovulate. So particular things like we heard that disrupt those higher brain centers and how they're sending out hormones will have an impact. And that can come down to those things like energy adequacy, stresses, potential overtraining and training loads. So they all need to be factored in as well. We are going to obviously look at energy balance in that context, but it's not just how much energy someone's getting, it's more fine-tuned with respect to their carbohydrate intake, how that's structured across the day and around their training sessions. So it's important to consider that as well for an individual, and really understanding what's someone enjoying at the moment, what do they like to be doing. Yes, they might love swimming, but all they're doing is swimming. So therefore, is it maybe too much swimming? Let's actually create some room for some strength training. And then something might have to be moved around or taken out of their training plan. Next slide. Okay, so when we're actually then working with clients and giving them the individualized exercise prescription, it's really important that we're monitoring that to know how are they responding, how are they going with their symptoms, how's their menstrual cycle tracking, are we trying to get it back, or is it because of PCOS that they don't have their menstrual cycle, and then we can look to bring that back. And structured activity will restore ovulation in 87% of women with PCOS. We've even had clients that have not had a period for 5 years and then have undertaken structured exercise and nutrition interventions, and they have gotten the return of their menstrual cycle, because we're addressing all of the underlying factors that lead to that anovulation. We are going to look at, again, their hormone levels across the menstrual cycle, understanding energy levels, sleep and mood disruptions. We can look at metabolic health markers that let us know how they're tracking. And we can also then have an understanding of even monitoring all of those loads that can impact our higher brain centers in both males and females, that can then sort of, shut off that production of hormones that leads to healthy production of sperm in our eggs. And we can do that by monitoring other aspects around autonomic function, or those higher brain centers, with some different tools like heart rate variability. If you're a highly trained athlete, you may have come across that before. But there's even research suggesting that this actually impacts reproductive outcomes from treatments like IVF. So we can actually start to monitor these things, see how someone's going with their exercise loads, and make adjustments accordingly. At the IVF project, we take we have a team of allied health professionals that are accredited, and we are aiming to address all of those factors that we know have an evidence base for impacting fertility. So that will be things like their physical activity, nutrient adequacy, sleep, looking at environmental exposures, and also incorporating our psychological well-being, which is an important component of the equation.
So when we're looking at undertaking a nutrition assessment and to understand what factors might be impacting conception, there's quite a few things that we're looking for, and we're using specialist software to find out all this information about what a client is doing. So we're obviously looking at their overall energy intake, and alongside that, obviously the distribution, which I'd already talked about. We're looking at the breakdown of what that energy looks like. So what's their fat, protein and carbohydrate intake looking like, and is that actually supporting their training sessions and what they're doing? So we're looking at nutritional adequacy of all of the vitamins and minerals, and also things like antioxidants, which we've already talked about, are playing a huge role. So it might be like vitamin E, C, vitamin A, and your omega-3 fatty acids, which are also really important. In addition to that, with respect to the fats, we're looking at the breakdown of the different types of fats. So how much is saturated, how much is unsaturated, what's the percentage of trans fats in the diet, because we know that all of those things can impact conception. So high saturated fat's going to drive up inflammation. We're looking at all of the different food group servings. So that's how many serves of fruit, how many serves of vegetables, how many whole grain serves is the person getting, nuts and seeds, as well as things like legumes, and looking at the amount of both caffeine and alcohol, which we know do impact conception. This is a little bit of a snapshot of what a nutrient analysis looks like with the software that we use. So in the graph on the left there, along the bottom, this is the percentage of dietary energy. And then so along the left-hand side, we've got the different macronutrients and what component that is taking up. So as you can see, this particular person has quite a high fat intake, and that's really putting an impact on the amount of carbohydrates that they're then getting in their diet, and as well as protein, and you can also see that their saturated fat is a little bit too high. On the right-hand side, this is the part of the nutrient analysis. So this was looking at someone's recommended dietary intakes of vitamins and minerals. So everything that's in the red there, the patient is not meeting the RDI for those vitamins and minerals, and everything in the green they are. And we can see that there's like pretty big, vitamins and minerals that have a pretty big impact on not only conception, but also fertility, also pregnancy, with regards to iron and iodine and folate, as well as their calcium intake. So that's just an example of the detail that we would go through as part of the nutrition assessment to understand what factors might be impacting their conception.
And then in tandem with that, obviously, to know what suitable physical activity is, we need to know how they're fueling their exercise. So we're also looking then at functional movement assessment, and we've got a few different tools and techniques that we utilize to go through that process and really understand the factors impacting conception, their functional movement side, and their nutrition assessment side. And then we can have a very bespoke, individualized approach for their exercise prescription and nutrition guidance that the client's receiving, absolutely specific to their circumstances.
Thank you to all our presenters. That was really informative and some really good takeaways from all of those talks. So before we just jump into the Q&A portion of the evening, we wanted to let you know that we are having an open night in both our Sydney and Melbourne flagship clinics. So this is a great opportunity to come and see where all the action happens. Because we are a full service clinic, everything that you need for your treatment is at the one location. So if you're tuning in tonight from Sydney or Melbourne and would like to come and see the space, be sure to register at the link in the chat. So it is time for the Q&A portion of the evening. We have had lots of really good questions coming through during the presentations. We may not have time to get through all of them, but we'll certainly do our best. So I might start with the first question. Chris, if I can direct the first one to you. We've had lots of questions come through from the male audience, which is really nice to see. The first question to you, Chris, is what advice do you give men in regards to their sperm quality with training recovery methods like ice baths and saunas?
I probably would, to be honest, I would focus more on what they were doing before they were recovering. I'm very happy for Celia to jump in. She's probably dealing with it more on a day-to-day basis, but it's more the intensity and the exercise that's being undertaken that's going to have a greater impact than the immediate post-recovery activity. It's still going to be important. What they're needing to recover from is a bigger component.
Just to add on to Chris there, definitely sauna exposure has been shown to reduce sperm quality. So we absolutely recommend that no one is engaging in saunas during the process. And we've done some hot water immersion research and even different durations of that in a like water sauna rather than just a hot air sauna. That will also have some potential impacts around thermoregulation, which we know can impact sperm quality. With respect to ice baths, actually, again, depending on the individual, a lot of work will actually show, and I've got colleagues that work in this area with respect to looking at what happens in the muscle with ice baths, and it actually would generate a lot more inflammation. So while the message in the general public is to have ice baths to help with recovery, it's actually just an added training stress. So you're adding more physiological load to your body. So you really need to be determining how that fits in with your fertility goals. So often in the Venn diagram of exercise performance being optimized and fertility, there might not be a huge amount of overlap, particularly when we're understanding what might be at play with respect to how healthy someone's menstrual cycle is, and also then looking at the male factors and sperm DNA fragmentation.
Perfect. Thanks, Cecilia. And I'm assuming, so another question just came through while you're talking. Presumably that would apply for men and women. There was a question about, the impacts on saunas for women.
So with female fertility, the thermoregulatory impacts are not necessarily as great with respect to looking at ovarian health and function. And even in early pregnancy, we're starting again to debunk some of those myths around like heat exposures, like from exercise, the heat that someone would generate in a standard exercise session, it's not going to impact their core temperature, in early pregnancy and have an impact on that. If they're exercising with fluids and, their exercise session duration is below an hour. Whereas for females, the sauna impacts, females are a little bit harder to research and quantify the direct impact of what's happening to their eggs, but the impacts of a sauna exposure are not as great for a female in terms of reproductive health and preconception as they are for males.
Thanks, Cecilia. Curly, I might give you this next question. Can a sudden change in diet, such as intermittent fasting or going vego, disrupt my menstrual cycle?
Short answer, yes. Certainly with intermittent fasting, and what I was trying to sort of allude to there with nutritional adequacy, you're potentially missing out on quite a lot of your not only dietary energy, but also nutrients. And if you're doing that potentially every day or at least a few days a week, and you've got quite a big energy deficit, then that's going to play into whether or not your body feels safe enough to produce those hormones, as Dr. Chris was explaining. So yes.
Thanks, Curly. Bev, I might give you, there's actually a couple of questions that have come through in relation to adenomyosis. So would adenomyosis impact implantation? How can it be managed when trying to conceive and also during pregnancy?
So I think if adenomyosis is present in isolation, then it probably doesn't have a huge effect on fertility. It depends on whether there are any other factors present, such as the woman is older, there's a male factor issue as well. But if it's there in isolation, then it probably won't affect fertility. And again, at Monash IVF, we've published some data to show that adenomyosis in the setting of IVF cycles doesn't affect pregnancy rates. Now, if someone has had multiple IVF cycles and they have very severe adenomyosis, because adenomyosis can be graded into mild, moderate, and severe. So if someone has had multiple IVF cycles and they have very severe adenomyosis, then certainly prior to an IVF cycle being undertaken, again, they can go on a regimen of a GnRH analog, such as Zoladex or Decapeptyl, which the IVF patients among the group may know. This causes the periods to stop and therefore stops feeding estrogen to the adenomyosis, and the adenomyosis can improve, and then an IVF cycle can be undertaken. But I would only suggest that in someone who has very severe adenomyosis, where the uterus is considerably enlarged, and if they've had cycles and it hasn't been successful.
Thanks for that, Bev. Supplements. A few questions coming through about supplements. Anyone feel free to jump in, anybody. One is in relation to protein powders. So I use a collagen-based protein and was wondering if I can continue using this through my IVF and hopefully pregnancy. Is creatine fine to continue using?
I can jump in if you like. Supplements, especially protein-based supplements, and potentially not really collagen because it doesn't really have the same effect as other protein supplements, depending on where they are processed. There's quite a high risk of contamination in the sports world, we call them banned substances, but obviously in the fertility world, no one's really worried about being banned from sport. But what that can come along with that is obviously potential contaminants in your protein powders that may not be too fabulous from a fertility perspective. So my recommendation for people looking at supplements would potentially look at supplements that are what are called batch tested, and there's two companies in Australia that do that. One's called Inform Sport and the other one is batch tested. And they will have a logo and a batch number, and they will tell you that that has the lowest risk of having any contaminated substances in them. That would be my recommendation.
Thanks, Curly. Again, feel free to jump in, anybody who has an answer to this one, but what level or type of exercise is safe during the first trimester?
jump in briefly here. In the first trimester, it really depends on what you've been doing pre-conception. So what type of activity has been your usual activity? I think it's really important to remember in that first trimester, you're essentially growing a new organ. You're trying to grow a placenta, you're trying to grow bubs. So you really need to make sure that you've got enough energy on board to contribute to those particular things going on internally. So if you continue doing what you're doing and you continue eating what you're eating, then where's that extra energy going to come from? Or where's the space for growing a placenta and growing bubs? So if you might need to modify your exercise intensity a little bit, particularly if you, depending on what's led you to have issues with conceiving in the first place, but you may need to reduce high intensity exercise just to make sure you've got a little bit of energy in reserve to contribute to that intensive growth that takes place in that first trimester. Generally speaking, if you've been doing moderate intensity activity prior, then it's safe and suitable to continue doing that as a global prescription.
Brilliant. Thanks, Cecilia. Chris, I might pass this next one to you. If I'm sedentary, how long should I have started to regularly exercise before I start egg freezing for optimal quality?
Well, that's probably a bit of a how long's a piece of string type of question, really, to be honest. Anything's better than nothing. Where are you in your journey at the time? How old are you? What was your AMH? What's your antral follicle count? What's your general habitus, your general diet? You know, there's a lot really to that question. We generally kind of think that the first 6 weeks, and again, Kirli and Cecilia might jump in and tell me where I'm getting things wrong, but generally the first 6 weeks is kind of an adaptation, and after that you're really starting to make some bigger changes. So I'd certainly suggest at least 6 weeks to get yourself into it. The other component is the habit forming component of it. We want this to be something that you're able to do and something that you're able to continue to do through your fertility and pregnancy journey, and then hopefully forever thereafter as well. And so, you know, that generally similarly takes around about that 6 weeks mark. Up to 12. Like the first couple of weeks, it's the worst thing that's ever happened to you. The next few weeks after that, you're kind of getting the hang of it. And by the time you get to the 12-week, that 3-month mark, it's the new you. You don't understand how you ever couldn't find the time to be able to fit it in. So I'd be suggesting if you've got the opportunity, you know, the 6 to 12 weeks, but mainly to make sure that this is now part of your life.
Yeah. Well, Bev, if you could answer this next one for us. I have extremely low ovarian reserve. At 38, my antral follicle count was 3 and AMH was 2. Can severe chronic stress throughout my life be a factor in causing this?
Very hard question to answer, actually. I don't know that I would. You've not the person has not always had an AMH of 3 or an antral follicle count of 2, or vice versa, right? This is something that has occurred over time. So I would say that probably not, but certainly chronic stress would make life pretty miserable. And if you are trying to become pregnant, the added stress of if you're having difficulty getting pregnant and if you need treatment to get pregnant, you're just adding all of your stresses together and making life pretty difficult. So I don't know that I'd say that chronic stress has caused a low ovarian reserve, but I think chronic stress will make life more difficult if you are trying to conceive, and if you conceive and after you've delivered a baby. I don't know if I answered that question, but anyway.
Thanks, Bev. I'm sure that there'll be many males in the audience hanging on every word to the answer to this next question. I'll open this out to the panel. How about golf and running for men? Is it good to support better quality of sperm?
Definitely movement is important and can benefit sperm. We've seen that. golf and running are two very different exercises, as are Pilates and strength training, and they'll have really different adaptations. And depending on what the goals are that you're trying to achieve, what you're trying to improve, whether it's aerobic fitness, mitochondrial health, reducing sperm DNA fragmentation, golf is very, very different from adaptations to running. And again, they're very different intensity exercise. So we'll deliver very different adaptations. It's probably best to look at a combination of aerobic-based activity, like running at certain intensities, play a bit of golf if you enjoy that and been out walking around the golf course, but add in some strength training. And we know that there are definitely additive benefits of combining aerobic training and resistance training in men for better sperm health.
Can't use the electric buggy. We must be walking around.
That's cheating.
It's cheating. And if you look at a bloke like Rory McIlroy and some of the golfers going around at the moment, Cecilia was talking about that they've incorporated quite a lot of strength training to improve their golf game as well. So go for a run, lift the weights, and you'll hit the ball further.
Good advice. Thanks, Chris. A couple of questions here about coenzyme Q10. Is it beneficial for egg quality? And also, what vitamin supplements would you recommend for women over 35 with a low egg count, if any?
Yeah. Did you want me to jump in there?
That'd be great. Thanks.
So CoQ10, I can just straight out say yes, it will be helpful. In terms of the what supplements would be helpful, that is a very individualized approach. So we do that as part of our nutrition assessment, understanding what is happening with the person. Obviously, there's age is one factor, but whether or not they have endometriosis or PCOS or what else is going on, and the supplements that we recommend are individualized.
If you're trying to fall pregnant, though, it's a good idea to be on folate.
Definitely do folate.
Thank you. Curly, this might be another one for you as well, actually. Can you please discuss the impacts of sugars in the diet and if it has an effect on egg quality?
So added sugar is something that we look at from an assessment perspective. And so some is okay, but too much is probably not okay. Definitely, high processed foods, potentially with added sugars and things, is likely to drive up inflammation, which is not going to be that great for your fertility. So, that would be my easy answer for that, but it's probably a complex question.
Great, thank you. Feel free to jump in with this next one. What about complementary therapies like acupuncture? Are they worthwhile?
I can answer that one. So there have been actually really some very good randomized controlled trials on acupuncture. There's probably been about 16 now. And some of them have shown that acupuncture is effective in implantation, and some have shown that it's not effective. And there have been quite well conducted trials. I think overall, there's probably no benefit in acupuncture, but what is really important to say is there is no harm either. And so if a lot of my patients say they like to do acupuncture because it keeps them calm. I'm not sure how getting needles stuck into you keeps you calm. It wouldn't keep me calm. But anyway, if the patient enjoys acupuncture, then I think go for it. It certainly won't harm the chances of getting pregnant. All of the studies that I've talked about with acupuncture are in the IVF setting.
Thanks, Beth. There's a few marathon runners in the audience tonight. Kirli, this might be one for you. But what would be your recommendation for fertility-friendly fueling on long runs, kind of 1.5 hours plus?
Yeah, so I purposely left out the during training nutrition in that first slide with respect to sports nutrition for fertility, probably because the recommendations coming from Cecilia might be that things might need to be moderated if you're trying to conceive. But if you are doing that, then definitely, similarly to your pre-training nutrition, you definitely need to have carbohydrates on board throughout a training session, and that would contribute to that increased energy availability and increased carbohydrate availability, and your body will be a lot happier.
Yeah, there's lots of work around even just the timing of nutrition and how that impacts gastrointestinal integrity, gastrointestinal damage that happens in running, the different intensity that run might be at. What are the after effects? Do they have enough recovery time then before their next session? So a few things that go into that, but definitely fueling during sessions is going to have a different physiological load and recovery time than if someone hasn't fueled or hydrated properly during that session.
Thank you both. We've probably got time for maybe 1 or 2 more questions. Again, feel free to jump in, anybody. But what nutritional supplements are best in the lead up to egg freezing for the best results?
I would probably say the same thing as before in terms of that's going to be quite individualised, but Dr. Chris obviously highlighted that you definitely need to be taking folate, potentially some iodine alongside with that, and we've already mentioned that CoQ10 is going to be helpful, but jump in to see a dietitian or a fertility dietitian, and they will be able to give you an individualised prescription on what is best prior to an egg freeze.
Just keeping in mind too that those eggs are maturing over anywhere from 4 months to 290 days. So anything they're exposed to in that time period is going to have a bit of an impact on them. So the longer preparation period you give yourself, then that's going to start to have the biggest impact and return.
Excellent, thank you. And just the last one, we've kind of touched on this throughout the evening, but how much is too much when weight training for males, and how much protein is ideal for men? Should they be supplementing with shakes, water, etc.?
I'll jump in briefly and Kiralee might elaborate. There's a great study done where they looked at men attending fertility clinics and trying to conceive that were taking protein powders. And what they did was then they stopped the males having protein powders and they found an improvement in pregnancy rates. So again, many reasons for that, contamination being one of them, but sometimes other factors in the protein powders are not necessarily supportive for male factor fertility. With respect to the first part as to how much weight training. So again, we know with different types of exercise sessions and different weight training sessions, there'll be different systemic responses with respect to how much inflammation is generated, how much intestinal damage takes place, and that then impacts the load of that session. And when their next one is, if we see males that are doing split routines, they're strength training 5 days a week, even though it's different body parts, that they're resting one day and working another the next day, we've got to appreciate that any exercise stimulus that happens at a suitable intensity, it's going to cause impacts that happen across the whole body. And those testicles where we're making sperm are going to be bathed in some of those inflammatory compounds that happen, and that's going to cause potentially a bit of disruption to spermatogenesis or making sperm. So if someone's doing a high intensity strength session, that does actually cause a bit of gut disruption, and we can see an increase in inflammation. That's okay, and stimulates adaptation. But if someone goes back the next day and does another intense session, then that's going to compound things. So a better general guidance might be that those gym sessions are split across the week where there's enough recovery time in between, and maybe it's a reduction in the volume of gym training, or that they are just putting those sessions into 2 days a week instead of split across 5 days, again, which has different systemic adaptations and impacts on sperm development. So training 5 to 6 days, 7 days at a high intensity every day, it's more than likely that's too much and going to have a negative impact on sperm.
I'll just touch on the protein component there. So the amount of protein that you need depends on what your lean mass is, or your lean muscle tissue. So at a minimum of sort of 1 gram protein per kilo of lean mass. Not everyone knows what their lean mass is unless you've done something like a DEXA, but a guide in terms of the amount of protein per meal is around about that 25 grams of protein we're looking for, but spread across the day. We call it drip fed across the day. So roughly every 3 to 4 hours, you might have a meal containing roughly about 25 grams of protein.
Great. Thanks so much. That was really informative. I'm sorry, that's all we're going to have time for tonight, but I apologise we didn't get to all of the questions, but yeah, please be welcome to scan the QR code to book in a complimentary nurse chat with one of our experienced fertility nurses. Thanks so much everyone for attending, and I wish you all the best for your fertility journey. Good night.